Hello, my dear. I'm Dr. Alaa Mosbah, Professor of Obstetrics and Gynecology, Faculty of Medicine, Mansoura University. Today, I have a very interesting topic in obstetrics, intrahepatic cholestasis of pregnancy. So, what are the objectives today? The definition of intrahepatic cholestasis, the epidemiology, etiology, diagnosis, treatment, and lastly, the prognosis. Okay, what about the definition of intrahepatic cholestasis of pregnancy? It is a liver disorder in late second and the early third trimester of pregnancy, and is characterized by pruritus with increased serum bile acids and other liver function tests. So, this is one of the liver disorder during the pregnancy, occur late in second and the early third trimester, manifested by pruritus and increased serum bile acids. Okay? So what about the epidemiology? Really, it is considered the most common pregnancy-related liver disorder. So you should care about this problem because it is the most common pregnancy-related liver disorder. What about the prevalence? The prevalence of disease varies geographically. Worldwide, worldwide prevalence ranging approximately between 0.3 and 5.6% of pregnancies. What are the countries with higher prevalence? Really higher prevalence seen in certain ethnic groups like Swedish, Chilean, South America, and Arconian Indians. Intrahepatic cholestasis of pregnancy has also been shown to be more frequent in pregnant women with more advanced age. Also in twin and the other multiple pregnancy. Also more in multipara. And in those with personal history of cholestasis due to oral contraceptive use. So when we see patient and you are suggesting intrahepatic cholestasis, ask her about her history in using oral contraception. Because she may give you positive result as regard the effect of oral contraceptive and causing cholestasis or symptoms related to cholestasis previously. Okay? So, this personal history of cholestasis due to oral contraceptive use in the past is important also. What about the etiology? Is the etiology well known or not? Really, etiology of intrahepatic cholestasis is not well understood, but most likely it is multifactorial. The hormonal changes, especially the high level of estrogen that occur during pregnancy in late second and early third, the maximum level of estrogen, okay, is responsible for this cholestasis with pregnancy. Maybe also progesterone, but mainly the high level of estrogen. That's why it occurs late second trimester and the early third trimester when the estrogen at the peak. Also may be related to geographic variability and the genetic susceptibility. So we have three factors here. Genetic factor, some women more susceptible to intrahepatic cholestasis. Hormonal factor related to hormones of pregnancy like estrogen and progesterone, but specifically or more especially the estrogen. The third one is environmental factor. Okay? Okay. The genetic susceptibility have been proposed as a possible mechanism of intrahepatic cholestasis. At least 10 different MDR3 mutations have been associated with intrahepatic cholestasis, of which the ABCB4 variant has been reported to be associated with severe form of intrahepatic cholestasis in pregnancy. Okay? So what about diagnosis? When the patient presents, as I said before, in late second trimester and the early third trimester, presenting to you with pruritus generalized one, but more prominent at the palm and the soles, okay? And getting worse during night time. What are the other symptoms that may happen? Anorexia, nausea, fatigue, right upper quadrant pain, pale stool, dark urine, or all symptoms of cholestasis. Jaundice may be present. It is variable in range. Some say from 5 to 10%, 14 to 25% of patients. But jaundice, when develop after 1 to 4 weeks of onset of pruritus. So pruritus is the presenting and the most important and the presenting first symptom. You should ask about the family history of liver dysfunction during pregnancy. Is it present or not? Because family history, if positive for liver dysfunction during pregnancy, also suggesting the theory of genetic cause. And it was found that yes, it can happen in sisters or in families in general, cholestasis related to pregnancy. So you should ask about family history of liver dysfunction during pregnancy. Physical examination reveals scratch marks on the skin from pruritus. What about laboratory finding? Laboratory finding, the most important one and the key laboratory finding include an increase in fasting serum bile acid concentration. And this is the first you should test for patient you are suggesting to be intrahepatic cholestasis in pregnancy. And is considered the most sensitive and specific marker for intrahepatic cholestasis. And usually we are using a cutoff value of 10 micromole per liter. Okay, so the cutoff for bile acid for intrahepatic cholestasis in pregnancy is 10 micromole per liter. And you should know that the risk for fetal complications increases in severe cholestasis with increased serum bile acid level over 40 micromole per liter. Please remember this number because it is important and related to perinatal morbidity and mortality. 40 micromole per liter, indicating severity of the cholestasis. What are the other laboratory abnormalities? Maybe elevated alanine aminotransferase doubled, aspartate aminotransferase doubled also, alkaline phosphatase increase up to fourfold direct and total bilirubin serum concentration increased. Steatorrhea is usually happening, and the prothrombin time may be prolonged due to vitamin K malabsorption, which can be exacerbated by cholestyramine therapy if we give that to the patient. Okay, we know that vitamin K of the one of the fat soluble vitamins and important for coagulation, and this is very important because it may cause antepartum, intrapartum, or postpartum hemorrhage due to the malabsorption of vitamin K. Okay, the next investigation you may need ultrasound. Yes, ultrasound is important. Why? Because I want to rule out the biliary obstruction. So, to diagnose intrahepatic cholestasis, you should exclude other causes like biliary obstruction. So, ultrasonography should be done in all cases of suspected intrahepatic cholestasis during pregnancy to rule out the biliary obstruction. What is the differential diagnosis? Two important differential diagnosis from other causes of pruritus and from other causes of liver disorder with pregnancy. Other causes of pruritus like prurigo in pregnancy, atopic dermatitis, pruritus gravidarum, allergic reaction, and pemphigoid gestational. Other causes of liver disorder like acute fatty liver of pregnancy, like HELLP syndrome with preeclampsia, like viral hepatitis, primary biliary cirrhosis, and drug-induced liver damage. What is the treatment? First, what our aim from treatment? Our aim of treatment to alleviate the maternal symptoms, and also what's very important really to decrease the risk of perinatal morbidity and mortality. And that's why worldwide all obstetricians are interested by intrahepatic cholestasis in pregnancy because it causes many morbidity and mortality for the baby. It may cause sudden death, intrauterine, fetal intrauterine death, intrauterine fetal death. Also, many other complications like preterm labor, like respiratory distress syndrome, admission to ICU. So it carry perinatal morbidity and mortality. That's why I wanna manage such condition and prevent this morbidity and mortality on the fetus and the neonate. Our first line of treatment is ursodeoxycholic acid given in a dose of 10 to 20 milligram per kilogram per day. Simply, I can say we should give the patient 300 milligram twice daily. Sometimes I may need to increase the dose to 300 milligram 3 times daily. Okay? Okay. What is the role of ursodeoxycholic acid? It modifies the bile acid pool, relieves pruritus, and improves liver biochemical tests, as well as the fetal outcome. And this is very important. Some obstetricians found cases refractory to treatment with ursodeoxycholic acid and severe cases. In such a condition, you can add rifampicin 300 milligram daily to ursodeoxycholic acid to enhance bile acid excretion. Rifampicin is hepatic enzyme inducer, which enhance bile acid detoxification and hepatic efflux of serum bile acid. That's why decrease bile acids and decrease the severity of cholestasis. So, in some refractory cases, I can add to orthodeoxycholic acid rifampicin. And all of us know that rifampicin is an antibiotic, broad-spectrum antibiotics used for mycobacterium infections, for TB. But here we are using it for intrahepatic cholestasis, being enzyme inducer and enhanced bile acid detoxification. If the first line treatment is not effective, you can go to another line of treatment by cholestyramine. Cholestyramine decreases the ileal absorption of bile salts, thereby increasing their fecal excretion. So I want to get rid of bile salts in stool, so I can use cholestyramine because it will decrease the ileal absorption of bile salts. Also for pruritus, I need symptomatic treatment, and antihistamine like chlorpheniramine is often used to alleviate the pruritus. Please remember, you should do fetal well-being test in the form of at least weekly biophysical profile to detect fetal compromise, also non-stress test. So please remember at least to do once weekly biophysical profile. As I said before, we have many risks as regard the fetus. Even sudden death may happen at any time. What about mode of delivery? Should I do cesarean section or vaginal delivery? Really, intrahepatic cholestasis of pregnancy is not an indication for cesarean delivery. Okay, so it depends on obstetric indication. You can do induction of labor if it's okay. If there is no contraindication, you can do induction of labor, or you can do elective cesarean section according to obstetric indication. Okay? What is the optimal time? This is very important, and I need all medical students and obstetricians to know this point. The optimal time of delivery between 36 to 37 weeks. Okay? With earlier delivery, when jaundice and the total bile acid level are more than 40 micromole per liter. Remember when I said, please remember this number, 40 micromole per liter for bile acid, this indicating severity of the case and severity of cholestasis and the severity of the risk as regard to the fetus. So, earlier delivery, some advise between 35 to 36 or at 36 if bile acid is more than 40 micromole per liter. Because you may be surprised with intrauterine fetal death suddenly. Please take care about this point. Okay, some authors said consider delivery before 37 weeks gestation in case of intrahepatic cholestasis if they have one of the following. Any one of the following. Maternal symptom with jaundice not improving with medications. This is number one. Number two, previous history of intrauterine fetal demise before 37 weeks secondary to intrahepatic cholestasis in pregnancy. Number three, total serum bile acid concentration of more than 100 micromole per liter. Also remember this number because it is associated with very hazards, very important hazard as regard to the fetus and the neonate, may cause perinatal morbidity and mortality. 100 micromole per liter for bile acid. Okay, so any one of these symptoms not improving and also associated with jaundice, pruritus with jaundice, not responding to medication, you should deliver earlier than 37. Or previous history of intrauterine fetal demise before 37 weeks, secondary to intrahepatic cholestasis in pregnancy. And the third item is total serum bile acid concentration of more than 100 micromole per liter. Should I give vitamin K before delivery? Yes. It's better to give vitamin K at least 6 hours before delivery to minimize the risk of postpartum hemorrhage. You can give it by injection, of course. And some advice to give vitamin K during antenatal care by oral administration also. Okay, because I'm suspecting that there is lack of absorption of vitamin K due to steatorrhea. And as I said before, this is one of the fat-soluble vitamins, and it is important for coagulation. By the way, cholestyramine, which is used for treatment of cholestasis, intrahepatic cholestasis, also leads to decrease vitamin K. So I have two factors, the disease itself and the treatment also can deteriorate the condition. So I am in need, yes, vitamin K, it's better to give it 6 hours before delivery to minimize the risk of postpartum hemorrhage. It is better. Okay. Postpartum monitoring is important and should do follow-up. For what? For bile acid. This is the most important. And the liver function test. And it should be done in 4 to 6 weeks to ensure resolution. So I'll do monitoring for bile acid and the other liver function test for 4 to 6 weeks to ensure resolution. Okay? What about breastfeeding? Is it allowed or not in intrahepatic cholestasis in pregnancy? Yes, after delivery, mothers with a history of intrahepatic cholestasis in pregnancy can breastfeed their infants. Okay, what about the prognosis? Intrahepatic cholestasis in pregnancy normally resolve within 4 to 6 weeks after delivery, and the good news also that pruritus begin to improve from the second day after delivery. And this is very nice, okay? Because pruritus is a very irritating symptom to the woman. And this is the good news. But the bad news is that this intrahepatic cholestasis can recur in the subsequent pregnancies. And the occurrence rate of intrahepatic cholestasis in subsequent pregnancies is high. It's about 60 to 70%. And you should expect it, and you should counsel the patient about that, to ask for medical advice early. So if pruritus and alkaline phosphatase elevation don't resolve after pregnancy, alternate conditions such as primary biliary cholangitis and the familial cholestatic disorder should be considered. You should ask yourself if the patient is not improving. As I said before, the patient should improve after delivery gradually. If pruritus and alkaline phosphatase elevation don't resolve after delivery, why this happen? There may be another pathology. There may be primary biliary cholangitis, maybe familial cholestatic disorder, and so on. Fetal complications associated with intrahepatic cholestasis in pregnancy include increased risk of preterm delivery, meconium-stained amniotic fluid, fetal distress, respiratory distress syndrome, stillbirth, and increasing neonatal mortality. Imagine how big is the problem on the baby. A role of bile acid entering the fetal lung and the depleting surfactant is also possible explanation for neonatal respiratory distress syndrome of the newborn of mothers with intrahepatic cholestasis in pregnancy. The catastrophe that may happen is sudden fetal death, and this is the most concerning complication of intrahepatic cholestasis in pregnancy. What is the cause of fetal death? Possibly has a relationship to toxic effect of bile acids on the fetal heart. The bile acids go inside the muscle of the heart and has a toxic effect, causing arrhythmia and cardiac arrest and prolonged PR interval and cardiac arrest. Also, one of the possibility is that the bile acid causing chorionic vasospasm, causing deprivation of maternal oxygenated blood to the fetus, causing asphyxia. So there is different mechanisms by which sudden fetal death may happen. One of them is the toxicity of bile acid over the heart, causing arrhythmia, cardiac arrest, and also the possibility of chorionic vasospasm causing asphyxia. Older studies reported perinatal mortality as high as 5 to 10%. This is very high perinatal mortality. But really, what is good news that the current active management leads to reduction in this perinatal mortality from 1 to 2%, reaching up to 1 to 2%, or even less than 1 to 2%. So, early management is important, and strict follow-up for the mother and the fetus by fetal well-being test, by physical profile. Taking the decision at the proper time for delivery is important also, as I said before. You may do the delivery at 35, 36, maximum 37. And according to the bile acid, as I said before, the risk increased if serum bile acid is more than 40 micromole per liter. And the risk is very high if reaching 100 micromole per liter, as I said before. Lastly, what about children? Children at the age of 16 born to women with intrahepatic cholestasis in pregnancy were also found to be at more risk of developing high body mass index and dyslipidemia. This is reported by some authors, and this is the end of my lecture. I hope it was clear enough. This is my box published on Amazon, textbook of obstetrics, textbook of gynecology, contraception handbook, and the multiple choice question book. And this is my site on Amazon, and my site on YouTube channel, and my site on Blogspot. Thank you, everybody. Wishing you the best.